Hello, my name is Cherry Kim, and today I'm excited to present the key findings from my recent study entitled Impact of Deep Learning-Based Image Conversion on Fully Automated Coronary Artery Calcium Scoring using Thin Slice, Sharp-Kernel, Non-Gated, Low-Dose chest CT scans. Coronary artery calcium scoring, or CAC, is a powerful predictor of future cardiovascular events. Traditionally, accurate CAC measurement relies on ECG-gated, dedicated cardiac CT. However, with the widespread adoption of low-dose chest CT, which is LDCT, for lung cancer screening, we increasingly encounter incidental CAC findings. Unfortunately, LDCT images are typically reconstructed with thin slices and sharp kernels, which increases image noise and reduces the accuracy of automated CAC scoring. This variability across institutions and protocols has been a significant barrier to the broader clinical use of automated CAC quantification on LDCT. Deep learning-based image conversion techniques such as adjusting slice thickness or modifying the reconstruction kernel have been applied to chest CT to improve reproducibility in quantifying emphysema or radiomic features of thoracic lesions. Implementation of these imaging conversion techniques is expected to mitigate the effects of variability in LDCT scanning protocols. Therefore, we hypothesize that the application of deep learning-based image conversion techniques would enhance the performance of automated CAC quantification on LDCT image reconstructed with thin slice thickness and a sharp kernel. This study aimed to evaluate the impact of image conversion on the accuracy of automated CAC quantification using thin slice, sharp kernel, non-gated LDCT images collected from multiple institutions. We retrospectively collected 225 pairs of LDCT and dedicated calcium scoring CT, CSCT images from 4 institutions. All images were acquired using standardized protocols, with LDCT and CSCT performed with a 6-month interval. After applying strict inclusion and exclusion criteria, our final cohort included adults who had both scans and no prior coronary interventions. For the LDCT scans, we applied 2 proprietary image conversion algorithms. First, deep learning-based kernel conversion, which simulates a standard dose, low-frequency kernel from the original sharp kernel. And second, slice thickness conversion, which transforms 1 or 1.25 millimeter images to 3 millimeter using the RASOM method. This resulted in 4 LDCT dataset for each patient, which means the original LDCT, kernel converted LDCT, slice thickness converted, and both kernel and slice thickness converted. Finally, those 4 sets of LDCT images were used for analysis in this study. An automated CAC scoring was performed on each LDCT dataset using a commercial deep learning-based software. Manual scoring on CSCT by 2 expert radiologists served as the served as the reference standard. We compared the automated Agaston scores and risk category assignments from the LDCT datasets to the manual CAC results. We use those kind of statistical analysis methods, and those are our results. The baseline clinical characteristics and CT imaging parameters are presented in this table. And our deep learning-based image conversion significantly reduced image noise. The median noise decreased from 104.9 Hz per unit in the original LDCT to 38.2 Hz per unit after both kernel and thickness conversion with a statistically significant improvement. As you can see in this table, the mean bias of the automated Agaston score compared to manual CSCT was dramatically reduced in both kernel and slice thickness converted images. The CCC for Agaston score, volume score, and peak density improved after combined conversion, indicating excellent agreement. In terms of risk category assignment, the agreement with the reference standard improved from poor in the original LDCT to good after both conversions. Both kernel and slice thickness converted image correctly assigned 77.3% to the same risk category as CSCT. 19.1% were placed in a neighboring category, and 3.6% differed by 2 categories from CSCT. The risk categories of 37 cases were overestimated, and 14 cases were underestimated. Overestimations primarily occurred because of noise near the coronary artery areas being misinterpreted as CACC, pulmonary veins adjacent to the heart being mistaken for left circumflex artery calcification, and motion artifacts. All 14 cases of underestimation occurred entirely due to detection failure, which resulted from the reduction of calcification to less than 130 Hz per unit during the image reconstruction process. To sum up, the present study demonstrated the effect of combined kernel and slice thickness conversion techniques on fully automated CAC scoring in non-gated LDCT scans with thin slices and Sharp-Kernel reconstruction. And the image conversion performed for LDCT image significantly decreased image noise and improved the agreement and reliability of automatic CACC scoring compared with the CSCT at both per subject and per artery levels. Our study has several limitations. First, our data set included a high proportion of participants with CAC was 0, so further research with more diverse populations is needed. Second, although we allowed up to 6 months interval between CSCT and LDCT scans based on prior studies, performing both scans on the same day would have minimized the potential impact of CAC progression. Third, due to our relatively small sample size, we did not correlate our result with cardiovascular outcomes, highlighting the need for larger multi-center studies to validate our findings and assess clinical relevance. To conclude, automated CAC measurement using image conversion on LDCT scans originally obtained with thin slices and Sharp-Kernel demonstrated excellent accuracy compared with manual scoring in multi-institutional dataset. However, further improvements in image conversion techniques are required to achieve more accurate results. This work was made possible thanks to the collaboration of our co-authors, and for more details, please see our full paper, which is available soon. Thank you for watching.